So this talk is designed primarily for new families, but it serves as a review for those who've been to camp before or to the adult meetings or other places that have heard me. There will not be a test, and it may be perceived, but it's really not too much information after you digest it. And that's why you can look through the slides. There'll be a lot of definitions that will go by very quickly, but they're on the slides. So why is it called FA 101? Well, in an American university, an introductory course is called 1, like Biology 1. But a more advanced course is 101. And this is more advanced because everybody who's listening probably knows something about FA or they wouldn't be here. What I'm going to talk about used to be labeled benign hematology, although apparently now they've changed that term to non-malignant. I'm not quite sure why. In any event, there's a list of what we call the inherited bone marrow failure syndromes, naturally abbreviated IBMFS. That's a little easier to say. They all share an increased risk of leukemia. They all have some kind of blood problem, either full aplastic anemia, reduction of all cell lines, or just anemia, or just white cells, or just platelets. But what the top two on the list, and Fanconi's at the top of this, they share solid tumors of a kind abbreviated SCC, squamous cell carcinoma. And this is something we've come to recognize probably in the last 15 or 20 years, but that we weren't aware of early on in the days of studying Fanconi. Dyskeratosis congenita also has those same kinds of cancers. Diamond-Blackfan anemia has its own category of cancers, and the others, mainly just leukemia, have been reported. So now this is where normally I would be looking out and people would raise their hands, but this time these are rhetorical questions. You don't have to raise your hand because I can't see it, but think of this. How many are new? Well, I have heard that something like at least half or more of the attendees have never been to such a meeting. How many have been here before? These are sort of Slack questions, which is you need to connect with those who've been here before. Those who are over 18 certainly want to connect with each other. And this is really important because some of what I'm going to talk about relates to this. How many of you think that the diagnosis was initially missed by one or more physicians? And at this point, if this were a live meeting, all the hands in the room would be up. And then how many were called something called VOTR, which I will elaborate on later. And that's a subset of the Fanconi, probably between 5 and 20%. So what is the symptom that led to Fanconi anemia being diagnosed? Well, it's varied. It could be physical findings because between a quarter and half of the patients have some problem with their thumbs, some as overt as missing a thumb, others as subtle as a flattening of the muscle at the base of the thumb. It's called the thenar, and many people are not aware of that. There may be skin findings. We call them cafe au lait. They're brown spots on the light skin, or they're darker spots on dark skin. It looks like a cup of cafe au lait. Endocrine disorders such as short stature, well, I'll show a picture of myself in a bit, and that could be me, but it isn't. Renal findings such as an absent kidney or a kidney that's in the wrong place in the belly is possible. Usually the kidney functions normally in FA, but not entirely. And then the blood problems, which I'll elaborate on, aplastic anemia, inability to make blood, MDS, myelodysplastic syndrome, which is in some contexts on the way to leukemia, but not always. And I like to show this slide that I borrowed from Dr. Steve Holland, who borrowed it from someone else, I'm sure. But this is the traditional blind man and the elephant, where what you think the animal has or is depends on your perspective. And I've replaced all these with Fanconi elephant, where the perspective, as you see, depends on the ear, the eye, the oral surgeon, the dentist, the hand surgeon, the geneticist, the hematologist or oncologist, the dermatologist, and the endocrinologist, just to name a few. And I ran out of places to put all the specialties. So, what do we find in any of the inherited bone marrow failure syndromes? Low blood counts, called pancytopenia. Cyto is cell, penia is shortage, and pan is all. Large red blood cells, macro is big cells. And I probably one of the few people who will ask you, what is the mean cell volume on your lab slip, your MCV? Because I want to look at the size of the red cells. A high fetal hemoglobin. Fetal hemoglobin is the hemoglobin that the fetus has in utero, and it carries oxygen better than the normal adult oxygen, so that's how the fetus gets oxygenated. But it tends to go away after birth, although it remains somewhat elevated in the marrow failure syndromes. There are syndrome-specific tests, and many of you have had at least one of these. The Fanconi test is looking for chromosome breakage in blood cells, usually lymphocytes, or skin cells called fibroblasts, cultured with DEB, diepoxybutane, or MMC, mitomycin C. The other tests are for the other syndromes, although in patients who we see at the National Cancer Institute, we do all these tests so we know the sensitivity and specificity of the tests. Now, the history of Fanconi anemia goes back to 1927, when Guido Fanconi, a pediatrician in Switzerland, in the Italian part of Switzerland, described three brothers. This is not one, this is a sister, but described three brothers who had low blood counts and physical abnormalities, including large red cells, which are usually seen in a disease seen in adults occasionally called vitamin B12 deficiency or pernicious anemia. And so he used the German word, actually, perniciosiform. It is not Fanconi syndrome. The same Dr. Fanconi is responsible, but that's a renal functional abnormality, which he described in 1936 with proteinuria, glucose being spilled, phosphate, and other problems. These are functional renal abnormalities. So although it has been suggested that those of you who are calling yourselves Fanconi anemia really should be Fanconi syndrome, that term is already used, and I tend to try to not rename things, because when you try to review the old literature, it gets really confusing. Now, this is a patient, and I can show it. He's also, if you go into Google Images, his picture is there, and we've published him more than once. So that's why I can show him. And I don't like to cover the eyes of patients, which may hide their identity, because the eyes are very important. These are very Asian appearing eyes. This is the chagrined look of a young man who wonders why we're looking at him like this. But he had multiple abnormalities. He had dangling thumbs, as you can see, they're not really functional. He had to have his ureters reimplanted. That's his renal defect. He had a rather large cafe au lait spot there, and several others, as you can see, including hypopigmented areas, dislocated hips, imperforate anus, which required surgery, rocker bottom feet, couldn't stand up very well, and I stood in front of him. This is a classical pediatric thing. Stood in front of him, raised my arms, so he raised his arms. Subsequently, we were informed about a cousin of his whose face looks very similar. And it looks like she's holding onto the crib with her thumbs behind, but in fact, she had absent thumbs. And unfortunately, both of these young children died with brain tumors. And I'm going to come back to that because it's a specific genotype within Fanconi that have brain tumors. These are pictures of adults. And these are twins who are identical, not just in their clothing, but genetically. And they were diagnosed at birth because one of them is missing a radius and thumb, although the other one is perfectly normal. We have yet to really explain the difference in this biology. This patient had aplastic anemia. He couldn't remember why he was diagnosed. These young men developed aplastic anemia at an older age. She had head and neck cancer, really tongue cancer, and had not been diagnosed as Fanconi until the cancer. And this individual was diagnosed because she was to be a transplant donor for her 42-year-old sister. So the age at diagnosis was not always clear. This woman had breast cancer, but her sister did not. Uh, these individuals with 2 stars had head and neck cancer, and some of them had had transplants, but not everyone. And there I am as the height monitor. So I have short stature. I line up with many of the patients, whereas these young men are quite taller. And this young man, who many may remember, came to me at one of the meetings and said, there's somebody taller than me. And that was this person who came to one of the meetings. Now, as you may be aware, there's a series of adult meetings. I think this 2016 might have been the first. I'm not sure. Maybe the first that I have a picture of. There were about 40 people here, half of whom had had a transplant, a dozen of whom had had cancer. And then the next year, about a dozen came to both meetings. And interesting to me, they tended to sit in the same place with the same people. And the tall people tended to gravitate to the back. This is the meeting from 2018. I think one of them dressed up, but others were dressed more than they would dress at camp. And this is last year's meeting, which had a large number of individuals, and not in the picture because I didn't get a picture of them, but half a dozen of the patients here had little children who were crawling around on the floor. It would have been nice to include them. So what is Fanconi anemia all about? Genetically, it's what's called an autosomal recessive, and I'm going to explain that to you in more detail. But what that means is that your chromosomes consist of 2 X's or an X and a Y for males, and all the others are called, they're not X or Y, so they're called autosomes, meaning they're found in males or females. One of the genes, FANCB, is X-linked, and one is a dominant. The physical findings may have led to diagnosis. Aplastic anemia, leukemia, solid tumors can be the presentation before the patient knows they have FA. Chromosome instability, these are pictures of chromosomes, and the arrows are pointing to unusual events, rearrangements or joining, gaps, reduplication here, and more rearrangement. It's considered a DNA repair defect. There's a lot of biology, and you're going to hear about that from other speakers. And I say there are at least 22 genes because about 5% of the patients, we still have not identified the gene. The age at diagnosis in literature review that Akiko Shimamura and I did a number of years ago now, my goodness, 10 years ago, but it still holds, which is the median, which is about half the patients are diagnosed by the time they're 6 or 7 or 8. And then there are some diagnosed at birth and some throughout age, including our older woman who was 53 at the time of diagnosis. The physical findings, and I'll show you several different representations of this, but this was the one that we described 10 years ago. The literature cases, the male to female is about equal statistically, although a slight excess of males in all the reports in the literature, which are more than 2,000. And there are physical findings in more than half the patients. Low birth weight, that could have been me. Short stature, but thumb abnormalities, as I said, in this case, 30% of the literature cases. The skin abnormalities, male gonads may be small, undescended testes, heads may be small, structural kidney abnormalities, small eyes, the skin findings I've shown you, and a variety of other things. Now, this is the young man I showed you earlier, and we've expanded the VOTR acronym to VACTERL: vertebral abnormalities, anal atresia, cardiac, congenital heart disease, TE fistula, tracheoesophageal fistula, renal abnormalities, L for limb, and H for hydrocephalus, which is exceedingly rare, probably not found in the Fanconi group. It's an association because there are many genetic disorders, and many that we don't understand yet, that lead to this complex. And if there are at least 3 out of the 8, the individual is called Vater or Vacteral. This individual had the limb abnormality, the kidney. He actually had the anal atresia, some vertebral abnormalities. And so my colleague, Dr. Geary, and I, whom some of you know, created another acronym. We looked at all the patients in our group who have Vater and found that many of the ones with Vater also had at least 4 out of 6 other abnormalities that are not in the Vater complex or association. And we crowdsourced it amongst all the people in our group, and they came up with an abbreviation called PHENOS, which I like because they came up with others, but I took this one because for me it's the phenotype or the physical finding. So P is for pigmentation, H is for small head, E is small eyes, and central nervous system, i.e. brain structural abnormalities. O is for otology, which is hearing and ear structure, and S for short stature. And it was very hard to come up with things that are unique. Well, if you put all this together, what we want to say is that if the geneticist is seeing somebody that they want to call Vater, we say, look for these things, and also look for structural kidney and limb abnormalities, and test for Fanconi. There's another concept that some of you may have heard called the Fanconi facies. It turns out it includes small eyes, a small chin, and a sort of a triangular face. But when Dr. Geary and I looked at the pictures of all our patients, every one of them who we would have said had an FA face had small eyes. So we didn't want to be redundant. And we had the PH sound already from the phenos, so we didn't want to complicate things any more than they already are. And this is a relook at the physical findings by Moises Fiesca-Roja from Mexico City, who spent 2 years with us. And he re-reviewed the literature and focused on the literature where the gene was identified. But in any case, this is the physical findings from the literature. And what you see is in those who had any of the Vater features, the kidney structure and the upper limb were most prominent. Amongst the phenos findings, the skin pigment, particularly the cafe au lait, but sometimes just some dark skin at the neck and other regions, the short stature, which is somewhat nonspecific, and the small head are the most frequent. And then there are a variety of other things that have been described, but many of them are nonspecific and occur in other disorders as well. Amongst the literature cases, 20% of the cases reported didn't have any abnormality described. That may be just underreporting, and that's the weakness of trying to do a literature study for certain features. Amongst those who were reported and had only short stature, it looks like about 5% of the literature cases, probably more in our experience. So the physical findings that are described in the literature may not be found in all persons, but you don't know from a literature report unless they say so. In any event, of those where something was reported, 5 to 10% were short and had skin findings only, and at least 20% of those reported had no physical findings. And some of the persons without physical findings may be diagnosed at a later age, such as the woman on the far right of the panoply of adults who was substantially taller than me, weighed more than me, and didn't have any of the physical findings. And so as we learn about new genes, and some of you who have followed this know that we still are waiting to find more, we can expand the phenotype because we've suddenly identified somebody with FA. Now, who should be tested? Anybody with the characteristic birth defects that I've described, aplastic anemia, MDS, AML, fertility problems. I'm not suggesting to screen all fertility clinics, but if somebody comes in with aplastic anemia and reports decreased fertility, that should be a red flag. The early characteristic cancers that I'll say more about, and siblings, of course. And this glossary, I'm not going to read through it because it is in what I believe was sent to you as a handout, and ask the FARF if it has not. But these are the technical terms that you're probably going to hear a lot of throughout the meeting. Now, this is a chromosome. It has two pieces that are identical called chromatids. The top part is usually shorter, so it's the P arm, and the bottom is usually longer. It's the Q arm. That maybe, don't think that's where mind your P's and Q's came from. But in any event, within the chromosome is the DNA, which is a string of molecules that wind up and carry genetic material. And this is what's called the double helix, for which Watson and Crick got the Nobel Prize. These are the nucleotides ATGC, and they pair with each other. And if there's a mutation, a single nucleotide polymorphism that may change one of these, then it also forces a change in the partner, or things don't work. So here's some more terminology. As I mentioned, the female's XX, the male's XY. In the recessive disease, I'll show you in a moment, but each parent carries one variant and one normal. The X-linked is, I'll explain. Homozygous means that there are two copies of the identical allele that came from each parent, whereas biallelic means each parent has a mutation in the same gene, but they're not identical at the nucleotide level. So they're two variant alleles. And then a heterozygote, otherwise known as a carrier, has one allele that is a variant or mutated, and the other is normal, and we sometimes call wild type. I'm not sure why, but that comes from the world of genetics, not hematology. So what are the tests? The chromosome breakage, which we've mentioned, complementation, I'll show you an example, sequencing of candidate genes. For example, Eastern European Jews carry a specific mutation in FANC-C called an intervening sequence for the fourth intervening sequence, 4 nucleotides along an A to a T. There's sequencing in a panel, which is the most recent and most efficient way to identify the gene, which is to put into this panel all the known genes and then just sequence everything. And then there are agnostic sequencing, where you're trying to find genes that you didn't have in your panel. And these are the terms used. The most common cells, as I mentioned, are blood lymphocytes or skin fibroblasts. These are more chromosome breakage from a different source, showing with the arrow a variety of abnormalities. And this is usually these days read still by a good person who can look under the microscope and look at the cells. And I forgot to mention, this slide came from Lisa Moreau at Dana-Farber, who works with Akiko Shimomura and others, including Alan DeAndrea. These names may be familiar to some of you. The complementation assay, which antedated the availability of knowing all the genes in the panels, was to culture cells with increasing concentrations of the crosslinker, in this case mitomycin C, and then add back what's called a vector carrying each of the known genes at the time. And this is the laboratory code. But in this particular patient, the only gene that made the cells more resistant and grew better at the low concentrations and sustained themselves at higher concentrations was FANC-A. So this used to be done, and I'm not sure how frequently it's done anymore. Now this is what's called a pie chart, and the biggest slice of the pie is FANC-A. It's about 70% of individuals worldwide. FANC-C and G are most frequent after that, And then there are all these other genes. Many of them are in 1 or 2 patients only, and there's about 5% that remain unknown. If you look very carefully, some of the genes have an asterisk, and that's because in carriers or heterozygotes, they are found to be mutated in one of their genes, not the other, in breast cancer patients, some ovarian cancer, some pancreatic cancer, some other cancers. So this is Moy's revised pathway, and there are many versions of this. But basically, if DNA damage occurs, the genes of the upstream or core complex have proteins, and if all those proteins are available to make this complex, then another gene can act on the genes from on the proteins from FANC-I and FANC-D2. It's called the ID complex. It's easier to say that way. And it adds a ubiquitin, which is an extra piece on. And only when that happens can the downstream complex, which, as I mentioned, are all those genes that sometimes in the heterozygote are associated with cancers. And that's called the downstream complex, which leads to DNA repair. So recessive inheritance, carriers, I've been asked this many times, and it's somewhere between 1 in 100 and 1 in 180 individuals worldwide. The birth rate is pretty uncommon, 1 in more than 100,000 new births. And the people with FA may have unaffected parents who are carriers. They have 1 normal gene and 1 mutated gene, but that is essentially normal. However, the affected offspring gets only the variant, the mutated allele or gene or chromosome from each parent. And on the other side is equally frequent at 25%, is the child who could get the normal gene from each parent. And in between are carrier children who can get 1 mutated gene and 1 normal gene from each parent. And then if the affected individual has a child, that child gets normal genes, presumably from the partner, but has to get an affected or a mutated gene from the Fanconi parent. And so they are what we call an obligate carrier. They only have 1 FA gene, and the chance of marrying a carrier of the same mutated gene, as I said, is pretty rare. It's a little more common, about 1 in 90 in Ashkenazi Jews or in certain founder mutation populations. But basically, this is the range. The dominant is on the left here, which is, here's a parent who has 1 Fanconi gene, but has all the symptoms. Now, this is dominant inheritance in general. It really doesn't apply in Fanconi because so far, all of the children we've seen with the dominant mutation have been new mutations. Their parents have actually been normal. The X-linked is shown on the other side, where the X could be present in a woman, but she's asymptomatic because she's got a normal X. And then she has a male child who might be affected, but that male child passes it on only to females because they're passing along the X, and those children are asymptomatic. And what I would suggest, if any of these terms are really confusing, talk to your doctor and go through that. Now, let's turn to blood for a moment. So here is what we call the pluripotent stem cell. It makes everything. It makes lymphoid cells, which are either T cells or B cells, or it makes everything else, which are called myeloid, which really should be the term for the white cells, the neutrophils, the monocytes, the eosinophils, and basophils. From this same stem cell come the progenitor cells that make red cells, or those that make progenitors and then precursors for platelets called megakaryocytes, which then make platelets. So if everything is not working, then all of these are reduced, but lymphocytes live longer than the other cells, so they may still be around. Now, I want to talk about mosaicism a bit. So in this case, there are, these are mosaic patterns on the floor or the wall of places in probably Africa or mostly Israel. It is variegated appearance. And it's suspected because the blood lymphocyte chromosome breakage test, which requires lymphocytes, may be normal. And I'll show you how that happens in a moment. But the skin test is abnormal. So occasionally, if a patient, we really suspect Fanconi, but their blood test is normal, then we ask for a skin biopsy. Now, this is a mock-up of a gene. So this is an individual who has Fanconi anemia. They have a mutated site on the gene, and then part of the gene, which is a long string, is normal. And on their other chromosome, let us say, they got a mutation from their other parent on a different part of the same gene, and they have the normal part of the gene. Well, when a cell divides, in order to divide the chromosomes and to divide the DNA, the chromosomes and the genes have to line up, as you see. And when that happens, then the DNA starts replicating. So in this case, it's replicating the wild type part of the same gene. And then because the middle is quite identical, it then slips over here and replicates this part. So it ends up with a part with 2 red parts and 2 blue parts. That is what the product is. And what they now have is a gene that has 2 different mutations on the same part of the gene, and then a wild type normal gene. And so they are now like a parent who had 1 normal gene and 1 gene with a mutation. Okay, we'll move along now. So what does it mean to have a cytopenia? Well, thrombocytopenia means low platelets, and it may manifest with bruises or little red spots. Anemia is low hemoglobin, which can lead to all sorts of symptoms from being anemic. And neutropenia, which are low white cells of the type that fight infection, have infections. So what are the complications? Well, with aplastic anemia, you have pancytopenia. All the cell types are down. And when the bone marrow is done, it looks like the cellularity is reduced. There may be leukemia, which is a malignant proliferation of immature cells, or myelodysplastic syndrome, which is often, but not necessarily always, on the pathway to leukemia and has, in Fanconi often, a hypocellular marrow. In the adult world of acquired MDS, a hypercellular or too many cells. The other complications are solid tumors, and in particular liver tumors, which Fanconi patients may get, particularly if they're taking androgens or male hormones. But these can be monitored, so it's not a definite outcome at all. So when do we treat the bone marrow? When the cytopenias reach what's now in the guideline book, which is online, so many of you can see it. It's published by the FARF, and it's going to be updated recently or in the near future. Hemoglobin less than 8, platelets less than 30, or neutrophils less than 500 are the tip-offs that really you need to do something. Or leukemia with blasts in the marrow, or funny-looking cells is all I can say for morphologic impression of what the cells look like. Androgens can be used. Often now patients go immediately to transplant, particularly if they have a donor who's a match or a sibling donor, and you're going to hear more from the transplant doctors. And some patients may go with what's called a haplo, a parent and other with an unrelated donor. Growth factors, generally speaking, may or may not work. The usually used versions are erythropoietin or EPO and GCSF or Neupogen, granulocyte colony stimulating factor. And gene therapy you're going to hear about. Supportive care can be giving red cells for anemia or symptomatic anemia or low hemoglobin, platelets for really low platelets or symptoms of low platelets. Blood products, we recommend not to using family members, even though they may be a good match, because you may want to reserve them to be a transplant donor, and you don't want to sensitize to minor groups that haven't been tested for. When we do use blood products, we usually try to filter out the white cells and maybe even irradiate the blood in case any white cells remained that might be dividing and engraft in something that isn't planned. And then as far as antibiotics, we recommend them as needed for infections, but not continuously. Now, transplant, the stem cell source is usually bone marrow. Nowadays, it could be cord blood. It might even be peripheral blood that was stimulated in the donor by giving them things like GCSF or other agents and driving things out of the marrow. For pediatrics, we tend to focus on bone marrow or sometimes cord blood. The donor can be an HLA-related donor when they meet criteria, or now an alternate donor, mismatched unrelated, it's called, or MUD, partial matched family member. These are more frequently used for urgent situations like leukemia, MDS, refractory aplastic anemia. And again, these decisions are made by the transplanter and the family. The preparative regimens include myeloablative or reduced intensity or non-myeloablative conditioning. And again, this is up to the transplant center and the family. So how many transplants have been done? Well, by now, probably about almost half of the Fanconi patients we know. But I must caution that some patients will never need a transplant. After transplant, half of the known transplants are now 5 to 10 years out, and overall survival is close to 90% with current methods. And again, this is between you and the transplant center. So what about age? The age, basically, everybody would like to do it young. They want to do it before there are complications. But certainly the need is whatever age criteria develop. We have published a couple of papers on something called preemptive transplant, which is statistically sort of rolling the dice or looking at the odds, because an elective transplant may have better results than one done under emergent circumstances. But on the other hand, half of those with FA may never need a transplant. And now it may be that those are the patients we don't know about till they get cancer, but it may not. There are some that we followed for years who just never needed a transplant. Again, this is between the patient and their physicians. Now, I want to say a little bit about cancer. So those who knew they had FA from aplastic anemia, birth defects, family history, or genotyping, and then got cancer, and those who got cancer and then were diagnosed with FA, maybe because they looked like they had FA, as the picture I showed you, or the family history, or they have Fanconi type cancers. And I think I'm running late, so just let me know if you need to stop me, please. Unrecognized marrow failure, absence of marrow involvement because of somatic mosaicism, or genotyping. The question's been asked, does every patient with mosaicism get cancer? It's the other way around. Some of those with cancer didn't know they had FA because they're mosaics. Causal factors for cancer in anyone: age, all of us. Genetics, probably. Following transplant, maybe mostly enhanced in FA. Human papillomavirus has been posited, although we're not convinced. And then there are other possible causes. So I want to say a word about FANC-D1 BRCA2 and FANC-N PALB2. The kind of cancers in children or young adults with these genotypes, leukemia, which is seen in other genotypes as well, but in this group only brain tumors, kidney tumor, or neuroblastoma. Other types of Fanconi, the primary cancer aside from AML is head and neck squamous cell carcinomas, particularly in the oral cavity more than the oropharynx, as well as some gynecologic squamous cell carcinomas, vulvar, vaginal, more than cervical. So this just shows that the most frequent in Fanconi overall are head and neck with esophageal and leukemia and vulvar, skin, and the median age of cancer, of any type, is 30, particularly the skin, from 4 to 58. But a lot of patients do get skin cancers, which is why, particularly when we're at Camp Sunshine, we focus on long sleeves, hats, and sunblock. That should be
Dr.
done.
Alter.
Yes.
Hi, this is Suzanne. I'm sorry to interrupt. I just want to give you a 2-minute warning. You have 2 minutes until it's ready to start question and answer, but that's up to you. So
I'm going to talk really fast now.
Okay.
But
Thank you.
Let me buy 5.
Okay.
Anyway, transplant or death from aplastic anemia is the most common problem with solid tumors and leukemia, not so much starting in adolescents and young adults. We've seen solid tumors after transplant, both in the Paris group and in the American group. We switched colors here, unfortunately. We're not sure of the cause. HPV, I'll skip through, which is that we don't all agree that it's causal, but we think everybody should get their vaccine. Malignancies are shown here in the proportion observed to expected or relative risk compared with the general population, and those who've been transplanted have even a higher relative risk. Non-brain, there are many non-brain tumor findings. There are many, including physical abnormalities, which is why we do the x-rays, the MRIs, sorry. And as I mentioned, the BRCA2 and PALB2 have brain leukemia, neuroblastoma, and Wilms as their signals at about the same age in the BRCA2s and the PALB2s. And we are trying to find out what the difference is between those who have had cancer and those who don't. Is it the type of mutation? We're working on that now. So I have reiterated, first of all, that any of these cancers, if a patient has more than one, they had to survive the first cancer. And secondly, that we would really like to have enrolled in our own study those who've not had cancer, because we're trying to understand the difference. Females, you can read about all the recommendations. It's in the guideline book. Immune functions are abnormal in some patients, but not everyone, at least in our experience. There is a marker for ovarian insufficiency for those who want to know whether they could have children, mostly the females. This particular marker is very low in the Fanconi, but normal in the carriers and in controls. And pregnancy may happen, but there may be complications. We recommend care under high-risk pregnancy doctors. The adult males, of course, have their own fertility problems. Everybody has endocrine problems and risks of cancer. The general surveillance is in the guideline book. And I will admit that sometimes they don't always tell us what they're doing, like the smoking and drinking. HPV vaccine should be given to everybody. Do not deny a Fanconi child the general vaccines that every other child gets. Endocrine surveillance is described, usually done by an endocrinologist. Now, what about transitioning? And maybe you can talk about this in some of your groups. What is the age? Who makes the decision? And how do you do it? And this is a great cartoon from New York Times Magazine. Who do you trust? Whose advice do you follow? What do you want to hear? How about the internet? How about mom? How about a good doctor? But this is where mutual decisions have to be made. We call it shared decision making. And what about carriers? Uh, the point I want to make is that PALB2, which is FANC-N, is also found in breast cancer families, in families that don't have BRCA1 or BRCA2 mutations. So the other Fanconi genes we've looked at very carefully, it's just been published. Your doctors can get hold of it if you cannot. And if the FARF reminds me, I'll send them a copy. And we have a website that you're welcome to go look at. It's marrowfailure.cancer.gov. We have a brochure. We have a ton of questionnaires, of course. We have a newsletter and the guideline book. And if this was camp, I'd say go find my pal, Dr. Geary, but you can't. So please call the 800 number if you'd like to join our study, and I'll talk more about it a little later. Stephanie Steinberg is the person you'll talk to. She's the intern nurse. Lisa Leithwood is the research nurse in charge of the whole study. Maureen Risch is the clinic nurse, and Ann Carr's genetic counselor. And when we all get back to seeing patients, we'd love to see you.
So we have a couple questions, Dr. Alter, on mosaicism, and wondering if patients that are mosaic are at greater risk of having cancer or leukemia compared to those that are not mosaic.
So that is in what I went through very quickly, but the question came the other way around, which is, did every patient with cancer have mosaicism? The mosaicism means that, generally speaking, the individual does not have the blood problems of Fanconi anemia. Their other tissues are still Fanconi tissues. And so they are not at an increased risk of cancer, but they are more likely to be seen as somebody who didn't have to go for transplant or who didn't have any of the blood complications. And so they survived to the age at which cancer was now a risk. I think there's one case of leukemia in someone who was a mosaic. And the mosaicism, I'm going to start talking with my hands now, means that not every stem cell in the marrow has had the gene correction. That may have occurred in only one stem cell, but the progeny, the children of that stem cell, now have a survival advantage because they don't have the DNA repair defect. So, but that doesn't mean that every stem cell sitting in their marrow has been replaced. So it's a possibility, but less likely, but has been reported.
Okay, thank you. And then we have another question about lung issues. We have heard quite a few cases of lung issues occurring in post-BMT patients, but the question is it a function of the BMTs or is it a feature of FA perhaps?
Yes and yes. Some of the modalities that were used to prepare people for transplant was total body irradiation. And that includes irradiating the thorax, which includes the lung fields. So, but that depends on the transplant center, and people are modifying things at this time. The other complication, of course, is if there's severe neutropenia or low granulocytes and the child or individual is getting a lot of infections and they may have had pneumonia, that may be the other reason. But it's more likely in the post-transplant in the era of irradiation.
Okay, thank you. Our next question is, can female patients with FA have children post-transplant 15 years after? Is it rare, and what is the likelihood?
Well, it is rare, but not unprecedented. The Paris group reported on this first. I don't know the frequency because part of it, of course, is knowing the frequency of people trying to get pregnant, and we don't have really good data on that. I would suggest that someone who's post-transplant who's concerned about that to see an obstetrician who focuses on what we call high-risk pregnancies and to ask for tests of their hormonal function. And that's why I showed the anti-Müllerian hormone, because that might be one of the measurements that would be useful. But this all should be done in conjunction with a high-risk obstetrician.
Okay, our next question is about post-BMT. If somebody's had a transplant, does that mean that they are considered to still have FA, or are they in remission?
So that was very interesting. The very first person who used that term was a older teenage girl who came to see me after her transplant. This is a lot of years ago, and said, "Dr. Alter, I don't have FA anymore." And my answer was, "You might, because the bone marrow transplant has only fixed the bone marrow. And the rest of the cells in the body, the ones where cancer can occur, may still be at risk, and the patient still needs to be monitored." I see you have a visitor in your online room.
This is new for me, and answering these questions, they come in pretty quickly. So just trying to prioritize, and thankfully ISIS is there to help me.
So let's tell people how many years we go back, Suzanne.
Oh gosh, a lot.
Right, exactly.
I have gray hair under this coloring.
Well, that's
Okay.
why I showed the picture of me in the doorway. That was when my hair was a different color. Okay, go ahead.
Okay, so we have another question about surveillance and extra monitoring. Is it recommended to have extra monitoring for people that are in the higher risk mutations, such as the FANK-J BRIP mutations, or BRP1?
Well, so the not the J. There are no brain tumors or any of the tumors that I mentioned in J. There are other problems, but those not brain tumors. The only brain tumors are in the D1 BRCA2 and the N PALB2. So those who are in those categories need to have ultrasounds to look at their kidneys and MRIs to be following the brain. We do for all genotypes recommend, but we can't enforce, annual bone marrow examinations, or certainly getting frequent blood counts. Yeah.
Okay, thank you. This one also has to do with monitoring or cancers. Is there research to show that parents of individuals with FA are more likely to be diagnosed with cancer?
Probably not. And we're just analyzing those data. We will submit an abstract for the symposium. But in general, those in the downstream region, the genes associated with breast cancer in non-FA families like BRCA1, BRCA2, PALB2, et cetera, might be at risk of breast or ovarian type cancer. But in general, carriers of the other genotypes are probably not. And again, that requires knowing the genotype and a conversation with the person, the parent's physician.
Okay, thank you. We have two questions about a similar topic. Wondering if females with FA can undergo IVF, and can females with FA have children possibly 15 years post-BMT, and what's the likelihood?
Well, so the second part I think we'd answered. And I do know of at least one FA patient who had IVF. So, that is something that perhaps, again, you all can talk about in your sessions together. But that requires going to physicians who work in the field.
Okay, and somebody is asking which cancer is the most common for FANK-A, it looks like.
Well, FANK-A is the most frequent genotype at 60 to 70% of patients. And overall, the most frequent cancers might be leukemia or head and neck cancer. And we certainly recommend starting at age 10 or 12, being scrutinized for oral cancer or head and neck cancer. And that requires good dental exams or seeing an ENT doctor who may do what's called a nasolaryngoscopy, which is to put a thin tube down the nose that has a fiber optic camera on the end and they can look.
Okay, more coaching for me. There's a question about the increased risk of GVHD and cancer. So is there an increased risk for cancer if you've had GVHD, whether it's acute or chronic?
I think the jury's still out on that. But certainly anybody who's had a transplant, whether or not they had GVHD, needs to up the frequency of the oral cancer screening. That's been one of the speculations, but I think that has to be asked of a transplant center, because we see a lot of patients who've not had a transplant, and so we don't have that data.
Okay. There's a question about a family who has a 31-year-old son with MDS that was diagnosed with FA. And the FA went undiagnosed since birth. He's scheduled to have a stem cell transplant, but it's been postponed because he has an infection in his brain called toxoplasmosis. So the question is, should the infection be gone completely before going to transplant?
This is a question for a transplanter.
Yeah.
I'm sorry. And also for somebody who I have not treated brain toxoplasmosis. So that's an infectious disease question as well. I'm sorry. I think the MDS, the urgency for the transplant really needs to be driven by how low the counts are, whether the patient needs transfusions, that sort of thing. So these are tough decisions, I know, and it's tougher right now.
Okay, so we're just trying to prioritize questions and put them together. So there's a question about whether or not the FANC-C complementation group has a higher risk of certain cancers to watch for.
Which group?
FANC-C.
C, as in ABC. Not that I'm aware of. But this is part of why we really need everybody we can get hold of to enroll in our study, those who do and those who do not have complications, because questions of the frequency of complications are really important, but we can't answer them if we don't have a denominator. Yeah.
And then another one about cancer, and wondering, does the process of pre-implantation genetic diagnosis, or PGD, increase the risk of cancer?
That, in Fanconi, we don't know in the general population, and we certainly don't know in cancer. In Fanconi. So I can't answer that. Again, I suspect we don't have data, because the PGD product is usually selected to not have Fanconi. So,
okay.
Yeah.
Okay, and then a question about how often somebody that's 20 years post-BMT should be getting screened for cancers.
Same as also, everybody else.
Yeah. Okay, and they're wondering if the lab work, having lab work done twice a year is sufficient, or if they should be having more screening.
Well, the lab work depends on what you're talking about, because the usual lab work is a blood count or liver tests or rule out diabetes, those sort of things, or endocrine tests. And so it depends what the lab work is for. So that's the best I can say. But as I say, unfortunately, somebody with FA who's had a successful transplant is very lucky, because now their bone marrow, by and large, has been cured, but the rest of their body still has FA. And that's for the gene therapy group. I know they're coming up.
Okay, great. And then there's a question about what is the most common cancer found in FANC-G?
FANC-G. We've not seen a lot of G. But I would assume that it would be like anything else, which is the head and neck and the gynecologic cancer. And I neglected to dwell on the gynecologic, but we encourage our FA females to see a gynecologist starting at age 16. They don't have to have an exam if they're not ready to do that. But the other thing that happens in FA is there's early menopause, which is that you stop having periods in your perhaps 30s at the latest, which gives a whole rise of new complications.
Okay, and we've had a few questions about the cancer risk for different complementation groups. So are you able to speak to what complementation groups are at risk for what cancers
That's one of the
specifically?
slides that I showed. And as I said, the BRCA2 and the PALB2, which are D1 and N, have their own little constellation of cancers, most of them young, but not always. And some of them have had other complications. And I think that's in the slides. But they're good questions. And generally speaking, everybody's at risk of the same stuff. And sometimes something new will pop up that we haven't listed.
Okay, thank you. I think we have time for one more question because it's about time to go to a break. So because it's pertinent to our time right now, are Fanconi patients more likely to have complications from COVID-19?
Good question. I don't have an answer, of course. I think we're all staying at home, and Fanconi families should stay home even more religiously, shall we say. Um, but if there's somebody in the family who's going out to work, for example, they should, change their clothes and shower and everything else when they get back before they touch the child. Um, there will be a study. The NIH is actually trying to start exactly that study, and they may be surveying, they may reach out to all of the Fanconi patients. And when they asked me whether we could participate, my answer was, I'm hoping that all our patients are well protected and not exposed. We just don't know. But remember, even in the general population, you can be an asymptomatic carrier. So it's unknown.
That's the hard part, isn't it? Okay, thank
Yes.
you, Dr. Alter.